morning to all of you. I'll a short presentation on varicose vein. So for undergraduate level. So he is a vascular surgeon, my guru. He is a general surgeon come vascular surgeon. Wherever I go, I start my presentation with this picture. I learn so many things from him. His famous saying is, no one will die of hard work. People will die of lack of work. So please do work more and learn more. This is a normal leg, that is a varicose vein leg. So common complication of varicose vein like thyroid is cosmetic disfigurement. In Western countries, this is a common cause for varicose vein surgery. What is the definition of varicose vein? It's a dilated, tortuous, elongated, thickened, subcutaneous vein which is more than 3 millimeter in size. The sites apart from lower limb, you can get varicose vein in spermatic cord, that is called varicocele, and then lower end of esophagus and rectum. So these rectum and esophagus you get in portal hypertension. Yeah. Then anatomy, 1 or 2 points I will highlight your level. One is saphenofemoral junction. So normally the standard teaching is, traditional teaching is 4 centimeter below and lateral to the pubic tubercle. Now the Bailey says 2.5 centimeter below and lateral to the pubic tubercle. With the 6 tributaries you need to ligate now, 6 tributaries. So superficial, see the lateral most is circumflex, superficial circumflex iliac, then superficial epigastric in the middle, then superficial external pudendal in the medial most, and deep external pudendal. These are the 4 branches. Apart from that, anterolateral thigh vein and posteromedial thigh vein. These are all the 6 branches you need to ligate in a open surgery for varicose vein. Yeah. So I enlightened at least 6 tributaries draining to LSV at the level of saphenofemoral junction can be the source of primary or recurrent varicose vein. We have superficial venous system, deep system and perforator system, 3 systems. What is the main draining system in the lower limb? Deep veins. This is the other way around in a lymphatic system. Lymphatic, we have superficial lymphatics and deep lymphatics through the muscular. So 85% it drains through the superficial lymphatics which is present in the skin and subcutaneous tissue. The deeper lymphatic which is in the muscle, it carries only 15% of the lymphatics. But whereas in upper limb, 80% of the venous drainage through the deep system. Only 20% drains through the superficial system. These are all the perforators in the in the superficial venous system. Perforator, it is the one which connects the superficial vein to deep veins. Maybe direct perforator or indirect perforator. What is direct perforator? Here. What is direct perforator? Direct perforator connects the superficial vein to deep veins without any intervening muscular channel. Whereas indirect perforator, they drains into the soleus and gastrocnemius venous plexus. Then that again drains into deep system. So direct perforators are the culprit. They cause the non-healing varicose ulcer. It directly supplies the deoxygenated blood to the ulcer. Continuously it supplies the deoxygenated blood that cause non-healing ulcer. That is the reason if you give sclerotherapy below the ankle, then all the direct perforator will be blocked, the ulcer will heal immediately. Then physiology, the factor promoting normal venous drainage is respiration, cough pump, tone of the venous valve and foot pump. If any of one is weak, patient develop varicose vein. In another take home messages, in a varicose ulcer there are so many theories were there, fibrin cuff, white cell trapping, these are all the old theories. Nothing is accepted except ambulatory venous hypertension. When there is a venous insufficiency, every time you walk, the pressure start increasing. So that is the reason why it is accepted theory. The venous ulcer very rarely present in the upper limb, even though you develop severe DVT, any venous insufficiency. So primary ambulatory venous hypertension is the accepted theory for varicose ulcer. Theory not accepted, these are all the theories, so no need to mention in the exam. And venous microangiopathy is another pathological reason for non-healing ulcer or cause for all the problem which occurs around the ankle. This is a basic pathology. See, as you get the dilated vessels in the lower limb, you get dilated capillaries in the pooling of the blood where it occurs in the gaiters area or around the medial and lateral malleolus. Then basement membrane will become thickened and endothelium will have space. Through the space, the leakage of the fluid will be there. That leakage will produce inflammation, fibrosis. That leads to all the changes. That fibrosis causes destruction of the microlymphatics. That is the reason for many chronic venous insufficiency patients. They have lymphedema. They have lymphedema like features with changes which occurs in elephantiasis, dry and fibrotic and then small elevated nodule skin. You can get in venous ulcer due to microlymphatics destruction. This is pathophysiology. And etiology, everyone knows: erect posture, prolonged standing, smoking, obesity and female because of the hormone. Secondary varicose vein. Yeah. Clinical features and all, I don't want to go. Yeah, we will see. A malleolar flare. What is ankle flare? Ankle flare. Dilated tortuous vein around the ankle due to ankle perforator incompetence. When this dilated tortuous vein around the ankle, that means the patient is immediately going for complications. It's itself an indication for intervention. Malleolar flare, ankle flare or corona phlebectasia. These are all the tests that Trendelenburg test 1 and 2. I always do the 2 first. You ligate the tunicate just below the saphenofemoral junction, make the patient to stand. You will see gradual filling from below upwards. See, usually this perforator incompetence 99% associated with saphenofemoral incompetence. Isolated perforator incompetence is a very, very, very rare entity. So whenever the test 2 is positive, automatically test 1 is also positive. Okay. So if the test 2 is positive, test 1 also must be positive in 99% of the people. Then Trendelenburg 1, you need immediately remove the tunicate, you will get fall from above. Yeah. Then 3 tunicate, more the tunicate you apply. Standard is 3 textbook. You apply more tunicate in the leg, you can locate the perforator exact site. Some people use 4 tunicate, some people use 5 tunicate. So that one is above, first tunicate below the saphenofemoral junction, second above the knee, third is below the knee. So if you see what is saphenopopliteal incompetence is seen posteriorly. So it is when you ligate the tunicate here and here, the bulge will be seen posteriorly. If there is a posterior bulge, it is saphenopopliteal incompetence. Even though the book says these tests are obsolete, you will be asked in the exam. The modified Perthes, this is the one test where you don't empty the vein. You fill the vein and make the patient to walk. If the deep system is blocked, they will have bursting pain and dilated veins. The size of the vein will increase. Yeah, one differential diagnosis for varicose vein is AV fistula. When will you suspect AV fistula? Young age, 16 to 25 age, congenital AV fistula and local gigantism. And third is dilated tortuous vein. When you elevate, normally vein will collapse. But in this patient, when you elevate the limb, the vein still will be dilated and tortuous. How to tell your diagnosis? Site, right side or left side, site, lower limb or upper limb or anywhere. Or side, right and left or bilateral. Complicated varicose vein or uncomplicated varicose vein, primary or secondary. This is the way you tell your diagnosis. CEPA classification. You expect only this. The PG level we expect everything. At least your UG level you should tell C1, C2, C3, C4, C5, C6. Right? These are all the complications. Management. Who is he? Who is he? Yeah, very good. Trent Lundberg. He is the father of vascular surgery or venous surgery. He is the one who identified that. He is the one who discovered that, what do you call that, brown bandage, no? Elastogray bandage. The venous duplex is the investigation of choice for varicose vein, investigation of choice for deep vein thrombosis. Okay. Investigation of choice is venous duplex. That antegrade flow usually marked in blue color, retrograde flow red color. So when you hear the sound, only monophasic sound will be there in the forward flow. When is unidirectional flow, you will see like that. That flow will be only one direction. But when you have a reflex, you will have a roaring sound. Like that, when you squeeze the muscle, when you do Valsalva maneuver, when you do dorsiflexion and plantar flexion, the reflex at the junction will be like a roaring sound, the lion roaring sound. That is the sound by which the radiologists identify the reflex in the saphenofemoral junction, saphenopopliteal junction and perforator. What are all the clinical tests you do, everything is demonstrated on duplex. Conservative management is called Biscott's principle, that everyone knows. SFG, see, we have three systems, saphenofemoral, saphenopopliteal and perforator. That is the reason for varicose vein. So saphenofemoral junction is treated by Trent-Lundberg surgery, the endovenous RFA and EVLA. So now the endovenous procedure is slowly replacing the open surgery. Still gold standard, you can say open surgery. What is followed in your institution, please tell. What is followed in your institution, please tell. I always tell, still surgery is gold standard, better to start with surgery. Trent-Lundberg. And so SPJ competence is again, here the saphenopopliteal junction is variant. You have to pre-mark the veins and then do the procedure under anesthesia. This is open surgery. Again, the longer you strip, lesser will be the recurrence. The olden days, they strip from the medial malleolus up to saphenofemoral junction. Because of nerve injury, below the knee, we don't strip. Complication of varicose vein surgery is bleeding. Main is groin infection. That is not present in endovenous surgery. Groin hematoma, groin infection, lymph leak, all this complication is not there in. And neovascularization also one of the complications, that is also not there in endovenous surgery. Principle in endovascular procedure, the integrity of the blood vessel, whether it is artery or vein, is maintained by endothelium. When you destroy the endothelium, it produces thrombosis, fibrosis, and then vein will disappear. That is the basic principle in all endovenous procedure. Thermal energy, chemical energy or mechanical energy. These are all three energies destroy the endothelium. Yeah. Okay, this is the laser fiber, RFA, both are mechanism are same. The MOCA is also recent advances, mechanical and chemical ablation of varicose vein. There is a catheter which is with the wings, all the sides. When you pull the wings, when you pull the wings, it destroys the endothelium. That is the latest one. This one is, this will rotate. There is a motor in that. When you switch on the motor, it will rotate. Handle will rotate and destroy the endothelium. At the same time, you can inject the sclerotherapy also. There are multiple holes in the catheter. This is MOCA. Then a cyanoacrylate glue, very costly. This glue itself will cost, I think, 75,000 rupees. So this procedure not gaining popularity in India. In abroad and all, they do this procedure, endovenous glue. Same endovenous glue is used for upper GI bleed. And then anastomotic bleed, in the vascular anastomosis, we put this glue to stop the bleeding. perforator incompetence, the treatment of choice is stab avulsion, that is the best. Apart from that, you can do subfacial ligation, sepsis, endoscopic perforator surgery, sclerotherapy. Very simple is sclerotherapy, what we do, very simple, you can repeat the procedure, but best is stab avulsion, old technology. Always old is gold. I still do the stab avulsion when there are the blowouts. Blowouts is better treated by only stab avulsion. This is a stab avulsion picture. Subfacial ligation of cockhead and dot, sepsis, sclerotherapy. Recurrent varicose vein mainly due to neovascularization, reflex in the residual vein, new junctional reflex, inadequate initial surgery. It is always or best treated by sclerotherapy. If the previous surgeon leaves major segment of the saphenofemoral vein or great saphenous vein, you can do stripping also. Biscot's regime, everyone should know. All varicose vein conservative management is called Biscott regime. Exercise, elevation, elastigray bandage. You can use certain drugs in varicose vein, pentoxifylline and ecosprin. It improve the microvascular circulation. These are the latest horse chestnut seed extract, 300 mg twice. Flavonoids, this is available, 500 mg dose. Sulodexide, this is a combination of these two. These are the drugs which can be used in venous pathology. Take home message, ambulatory venous hypertension is only accepted theory and Biscott's principle for all CVI lifelong. What is CVI? Chronic venous insufficiency, edema, skin change, ulcer. These three are called, any patient with edema leg, ulcer and skin changes, pigmentation, everything on lipodermatosclerosis. This is called chronic venous insufficiency. These people should have lifelong elastigray bandage. Chronic venous insufficiency is treatable or controllable, never curable. So these people will come with the recurrent ulcer unless they follow the lifelong advice of exercise, elastigray bandage and elevation. An endovascular procedure, slowly replacing the open procedure. Still open surgery is the gold standard. The lifetime take home message. This is my last slide. I think you would have read in the last CME. Be proud of your profession always. You are doing a holy profession in the society. Then have a positive attitude in your life always. Always. Yes, sir. Control your anger and temper. That is little difficult, but you can practice now itself. You have done, sir? Possible. Possible. Control your, but like Chanakya says, you can use your anger as a weapon once in a while, not every day. Once in a while, your anger will be respected very nicely by everyone. இப்போ நம்ம டெய்லி சிரிச்சிட்டே இருக்கிறோம், திடீர் ஒரு நாள் சீரியஸ் ஆகிட்டோன்னா என்ன ஆகும்? என்னதும் சாருக்கு பிடிக்காத என்னமோ நம்ம பண்ணிட்டோம் அப்படின்னு எல்லாரும் அப்படியே அமைதியாயிருவாங்க யூனிட்டில். சிரிச்சிட்டே இருக்கிறோம், திடீர் ஒரு நாள் சீரியஸ் ஆகிட்டோன்னா தட் சீரியஸ்னஸ் வில் கேவ் லாட் ஆஃப் வேல்யூ. நீங்கள் என்னைக்கும் திட்டிகிட்டே இருங்க, திடீர் ஒரு நாள் சிரிச்சா என்னடா இந்த ஆளுக்கு வட்டாயோ, இன்னைக்கு பார்த்து சிரிக்கிறாரு, ஏதோ இளையிட்டு போலுக்கு இந்த ஆளுக்கு அப்படி சொல்லுவான். ஸோ always use your anger as a weapon once in a while to control the other people. Not every day. Daily once. No. There is a daily once. At least have one meal per day with your family to improve the emotional bond. Always say, we have only one family. We should live for that. Illa? Sir, you can sacrifice anything for your family, not the family for anything.